Thank you very much. I'm Dr. Kevin Cavanaugh from HealthWatch USA, and I really appreciate the opportunity to speak to you all about healthcare-associated infections and multi-resistant drug organisms. Now, this is a huge problem. Currently, it's affecting approximately 1 in 25 hospitalized patients. It is a top 10 leading cause of death in the United States, and it equates to the crashing of one Boeing 767 every day. If you look in the United States, and this is hospital data, hospitals alone, the cost of this is $30 billion annually. In Kentucky, this would equate to almost $400 million, almost 1,400 lives lost from 23,000 infections. But this is not just a hospital problem. That's what everybody talks about. But in reality, this is a health system problem. Hospitals are less than 20% of the healthcare systems in the United States. And for example, when you were talking about readmission problems, well, hospitals are going to be fined for readmissions. Well, if you discharge to a skilled nursing home facility, they pick up a C. difficile infection, 2 weeks later they come back to your facility, the hospital gets dinged. So this is a healthcare system problem, and it's not in control of any one facility or facility type. Patients, families, friends from one facility goes into another facility. If you've got one facility in your network that has poor rates of control, it will affect your rate of control and affect all other facilities. Yes, you can screen on admissions, but screenings are not 100% accurate, and I bet you don't screen the family, friends, and staff that come in from that facility to visit yours. Now, this is data from the CDDEP, and it is somewhat old data. I will update these slides from, of course, the Wednesday CDC data, which was recently released. But multi-resistant drug organisms, as defined by the CDDEP, makes up approximately 20% of healthcare-associated infections. Now, the CDDEP uses an antibiotic resistance to an agent in 3 or more categories, antiseptic categories, as CDC uses 1 or more categories. So the data is not truly comparable. Now, if you notice here, they list MRSA as 8.5%. However, Wednesday's conference call at the CDC listed MRSA as approximately 11% of infections. C. difficile, 12% of healthcare-acquired infections. Now, an important concept is that the percentage of these infections which are from multi-resistant drug organisms is increasing. The fatality rate from multi-drug organisms is approximately twice that from a regular infection or an infection that's more antibiotic susceptible. And so if left unchecked, these organisms have the potential of doubling the fatality rate of healthcare-associated infections. That's provided the incidence of those infections stay the same. Hopefully, it will go down. Now, let's talk about just one of these types of infections, MRSA. The important point here is that 85% of MRSA infections is related to a healthcare setting, where this is a hospital, nursing home, or dialysis center. 85% are healthcare associated. 27% is hospital onset. But many times that's a short stay. You go out from the hospital, you can go out from a nursing home, you go back into the community, you develop your infection on an outpatient basis. The United States is not doing well compared to the rest of the world. In the United States, the percentage of staph cultures which are resistant to methicillin approximates 50%. We're the 3rd highest in the world. Now notice the Northern European countries, Sweden, Denmark, Norway, Netherlands, Finland, Iceland. They are under 5% resistance rate. They have a much more greater active and engaged and coordinated public health care system there, and they do use surveillance as a key component of control. Now, you'll hear because those countries are colder. Well, they're not any colder than Duluth, Minnesota. I'm sorry. And environmental effects can't explain that big of a difference. In Kentucky, we are in the region, according to the CDDEP, that has the highest percentage of staph cultures that are methicillin resistant. We're approximately 70%. So Northern Europe, less than 5%, United States, 50%, Kentucky, in our region, 70%. What is it in Kentucky? We don't know, because we do not have a good coordinated data collection system. Now, is this getting better? Just because I have an extremely complicated slide up here on this subject and not a simple yes or no, you should realize we have problems with our data collection system. The first survey system, which is the Emerging Infections Program, comes from 9 metropolitan areas that I feel are handpicked. They weren't randomly selected. They were selected to look for new organisms. And data from there has been extrapolated to the rest of the United States. And if you look at that, things look great. 21% decrease overall, hospital onset, 46% decrease. But all these other studies after it shows that things may not be so rosy. The Healthcare Cost and Utilization Project, or HCUP data, was reported by USA Today. I can't find this data anywhere else, but the USA Today reporter, Peter Eisler, got this from AHRQ. For year 2011, 46,000 hospitalizations involving MRSA, 23,000 deaths involving MRSA. In other words, the patient that died had that as a diagnostic code. University Healthcare Consortium, 2003 to 2008 data, they did not detect a decrease in MRSA. What's most disturbing is the NHSN data that's just posted. And this was data that was from 1/2013 to 3/2013 on bacteremia. And you will read that shows we did not meet our targets. Well, we went on the data.gov, downloaded the data file, and looked at the SIR. Now, the SIR is a standardized infection ratio. That is the starting point. That's not where you're supposed to be. A lot of people say, oh, we got an SIR 1, that's great. No, that's not great. That shows no improvement. The baseline data for this, I believe, is 2010. So 2013 data, SIR of 1.05. That is no improvement. And finally, pediatric data from a pediatric survey of healthcare facilities. Again, no improvement in MRSA. Now, we will be requiring reporting of MRSA. In fact, I think they are currently bacteremia. But that only captures a very small sample of infections. For example, in the picture on the right-hand side, very severe MRSA infection. I mean, if that was my hand, I would be scared I was going to die and it was going to fall off. But unless they were able to culture bacteria in the bloodstream, which many times it doesn't happen because they're already on antimicrobials far before it got to this point, this individual would not be reportable. All right, now comes the complicated part of the talk. How many people here don't have a good background in research and statistics and things like this, so I can kind of judge my audience here? All right, well, that means for clarity, I may sacrifice a bit of accuracy. You know, that always goes along with things, but hopefully it won't be too bad. Now, one of the biggest controversies is surveillance. Should we use surveillance? And in your handout, there are 2 articles, one letter and a main article that goes into some of what I feel are political forces behind surveillance. And I will go into a little bit of this as we talk through these studies. Now, on the left-hand side are 4 studies that I think are very good studies that found that surveillance was a key component to their prevention bundle. Now, surveillance alone will not work. You have to do something with it. First of all, you have to check the test result. It sounds ridiculous. Well, one of the studies, you could argue, didn't do that. That's being used to say it doesn't work. Second, you have to do some intervention when you get the result. You can't just do nothing with it. Of course it won't work. It's just a test. You have to look at the result, and then you have to do something. So surveillance always has to be implemented with a bundle. And down at the bottom, there's almost 40 other studies which have found a beneficial effect from surveillance. Now, you'll hear the fancy term, well, they didn't control for secular trends. What that means is there were a before and after study. Here we didn't do a surveillance. We had this rate. Now we did it. It fell to this rate. Therefore, it worked. And people say, oh, but it might have been another factor because you didn't have a concurrent control. But yet there are almost 40 studies that found beneficial effect. There are 3 studies which I feel have significant problems, which did not observe an effect with surveillance. So let's go over some of the studies that showed surveillance worked. Now, the first one was from Northwestern. This was a well-controlled study using surveillance, and I believe they also used decolonization. Universal surveillance, that's culturing everybody that comes into the hospital. They were able to decrease their infection rates by almost 70%. ICU was 36.2%. The next study is not talked about much, but this is, I think, also a very good study. This was out of Spain. This study was kind of a before and after study, where, as you can see, surveillance plus decolonization was introduced in period C, but they also had a concurrent control of methicillin-sensitive Staph aureus, and they looked at bacteremia. So they did surveillance for MRSA, decolonized, had a drop in bacteremia, but they didn't for the other category, methicillin-sensitive. And I thought that was kind of an interesting experimental design. Also, they had to do the decolonization. There are several studies that have shown that if all you focus on is hand washing, you're not going to be successful. There are also studies that have shown that if you don't focus on hand washing, you're not going to be successful. So it cuts both ways. It is a bundled approach. Now, the VA study is also a study that's a before and after study that has, you criticize because it could have what's called secular trends, or maybe something else happened. But the thing that is so unique about the VA study, it is a huge study. Started out in the Pittsburgh VA, then it was duplicated by every hospital in the VA system. And the initial study was published in 2011, 62% decrease of MRSA in the ICU, 45% in non-ICU. And they also emphasized hand washing. The Lexington VA in the Courier Journal, 95% decrease in MRSA infections. That is huge. They expanded this to nursing homes, 36% decrease in infections. Now, the final study that we're going to talk about is one by Lee. And this one, please kind of remember, because we'll be coming back to it repeatedly. This is a multi-institutional, multinational, huge study looking at surgical patients. And again, utilizing surveillance in their bundle. They also used decolonization with chlorhexidine for positive patients. So in other words, surveillance, it was part of the bundle. They had a significant decrease in MRSA. And so this is, I think, a very landmark study as far as preoperative patients. And we'll talk about it again a little later. And again, they looked at surgical wards. This is another study that found out that if you want things to be successful, you have to use a bundled approach. Hand hygiene alone wouldn't work. Surveillance alone wouldn't work. You'd need to do it with a bundle. So now let's look at the studies where surveillance didn't work. These are published in major journals. The first one was by Harbrath. This study, and this goes over in your paper, was actually one of the studies which we believe was quoted during a U.S. hearing on healthcare-associated infections. It occurred several weeks after the study was published. And I think it was one of the factors that kind of left everybody in a quandary, well, we can't do much. And this was on surgical patients. They found no effect of doing surveillance. But if you look at the study, In this study, 31% of the carriers that were identified as MRSA carriers were only identified after surgery. In other words, it came in on an emergency, so the tests weren't available beforehand. Of the patients that were known to be MRSA carriers before surgery, over 50% did not receive antibiotics effective against MRSA. Of the people who developed an infection, okay, and were known to be carriers before surgery, 34% did not receive prophylaxis for MRSA. 60% did not receive optimal decolonization for being a carrier. According to National Healthcare Service, that's 5 days of decolonization. And this study was effectively, I feel, negated by the previous study we talked about. Much larger study, multi-institutional, and not only this, but the Lee study, which I feel has negated the Harbreth study. Harbreth was the corresponding author on it. So he was actually very much involved in doing this updated, expanded work. Now, the other study you'll hear is the one in Huskins, and this was published in the New England Journal of Medicine alongside the VA study that we talked about. This study had arguably suboptimal contact precautions that were being followed by the staff. And the big problem with this study is that they did cultures, and it took 5 days to get the cultures back. They sent it, I believe, to Atlanta to come back. It took 5 days, and by that time, it really wasn't actionable for them to prevent the infections in a lot of the patients. And some of those were eliminated from the study, but still, you've got those patients that aren't undergoing the protocol, that are in the ICU, that may be spreading the pathogen. Now, the final study, and this I think there'll be a lot more to come out of chlorhexidine, had to do with Huang. And this was a recent study in New England Journal of Medicine. And this study advocated daily bathing of every patient every day in the ICU with chlorhexidine. And they found a beneficial effect, statistically significant, on MRSA cultures. They found a reduction in MRSA bacteremia, but did not reach statistical significance. But what was disturbing, and we've been actually kind of quite active in the literature on this, was that the metrics or measures were changed in trials.gov. The changes were recorded 6 months after trial completion date. The author wrote a letter and said that they were changed prior to trial completion, but still after trial initiation, and that these data will be reported, but we haven't seen them yet. And the data that was eliminated was for urinary tract infections, which I think that's an area, perineal area, would be very hard to clean with chlorhexidine. And they also eliminated CLABSIs, and then they added the antipathogen category, which was their big category that was showed a beneficial effect. So if you're a purist with research, this throws up all sorts of red flags. It's kind of like taking a test, and at the end of the test, you can pick and choose what questions you want to answer. So we said, this created concern. Now the author has assured us it hasn't happened. They are going to have this data, but nevertheless, to us it raised a red flag. Now this study was also validated, or the findings, by a study recently published in Lancet, which also did chlorhexidine bathing on individuals and found a significant decrease in MRSA acquisition. This would be both, acquisition would be both infections, colonization, et cetera, someone picks up the bug. They did not, however, find a decrease in vancomycin-resistant enterococcus and enterobacteria acquisitions. In other words, it worked on MRSA, but not everything else. Disturbingly, 13 to 14% of the individuals in that, of the Methicillin-resistant Staph aureus was found to be resistant to chlorhexidine. Now, the definition of resistance to this antiseptic is really up in the air. People don't know what a resistance to antiseptics are, because obviously it has to be bactericidal. It can't be bacteriostatic because there's nothing else to kill it. It has to be bactericidal. But it has been shown by another author, Lee, this is a separate Lee author, that if MRSA is resistant to chlorhexidine, it increases the chances of it persisting after decolonization with chlorhexidine. So that this study indicates that this resistance would be clinically significant. So there is a big question on resistance with chlorhexidine usage when it's used for an extended period of time. And that is an extremely, I think, important point. And also remember, antiseptics expose all the bacteria in your hospital to that substance. So it affects the whole facility's microbiome. So if you have a C. difficile problem, someone would wonder, well, is that what's driving it? Because spore-forming bacteria, they're resistant to chlorhexidine in a spore-forming state. They're also resistant to alcohol rubs. And so there's some questions here of if this should be widely adopted. It, of course, would be, I think, pretty staff intense to perform this intervention, and it also has this potential of resistance. And you'll hear, well, the authors didn't note that resistance occurred. Well, resistance doesn't slowly occur. Usually what happens is you get a chance mutation, the bacteria gets out of the setting, escapes Pandora's box, and all of a sudden you've got a huge problem. And this is data from the CDDEP, which shows that resistance sometimes can take 10 to 15 years to occur, but once it occurs, you're in trouble. Now, let's talk about preoperative patients. There is probably no area when you talk about MRSA prevention that surveillance isn't gaining more and more acceptance, even here in the United States, when it talks about preoperative screening. And this, I feel, is very crucial. With the exception of the initial study, Harborough, all the other studies have found a beneficial effect. And the very well-controlled study by Lee, of which Harborough was the corresponding author, found, again, a beneficial effect to screening. And screening on preoperative patients is important for a number of reasons. First of all, it is well established that if you are an MRSA carrier and you go to surgery, you have a much higher incidence of having an MRSA infection, a double or greater. And so that is very important to know. The second is it would determine the length of time that you would decolonize that patient. Most patients, when they go for surgery, will undergo a single bathing with chlorhexidine or Hibiclens. But if you are an MRSA carrier, there are institutions that have protocols that will use 5 days of decolonization and then want to have 3 sets of cultures afterwards, being negative before proceeding with the elective surgery. And also the type of antibiotic that you use may well vary. If you're an MRSA carrier, you'd want to use vancomycin. If you're not an MRSA carrier, there are studies that would indicate that cefazolin may be more appropriate because vancomycin may not be as strong an antibiotic in preventing other types of infections. So it may determine the type of antibiotic that's used. And certainly you don't want to use vancomycin on everybody, or you're going to start to see vancomycin-resistant MRSA. I mean, that has already popped up rarely around the nation. We don't want to have it getting a foothold. Now, when you look at the National Health Service, they mandate screening for all high-risk patients. And this is a list of them. And this is in your handout, what their recommendations are. Orthopedic patients, cardiothoracic, neurosurgery, emergency room patients, critical care admissions, all elective surgical admissions, previous MRSA carriers, oncology chemotherapy patients, renal patients, patients admitted for high-risk settings from homes, and all emergency admissions. I mean, that's a slew of patients. And then at the end of their recommendations, they essentially say that, look, we're testing so many patients that the logical conclusion is universal screening of all admissions. Although that's not mandated, that's what was recommended. And preoperative patients, I need to add, when you do screening, you do not have to do a rapid test. You can do a $10 culture because you've got, you may have weeks before that surgery comes. So it's very low cost. Insurance covers it. I know it covered it for my surgery. And it's something I would definitely recommend doing. This is a graft of MRSA bacteremia at one of the hospitals in England after instituting these protocols, and you can see it just literally bottomed out. Sort of the graft that we're seeing in our Veterans Administration system. So screening is something I think that should be done. There's more and more evidence. I know that you will hear a lot about cost, but you're really talking about a rapid test, $50. No one thinks much about a cost of getting MRI scans or CT scans in ERs, which I think are, could be cut back some. And so this is an area I think that investing in this type of interventions would be extremely beneficial. So thank you. Is there any questions at all?